afternoon to the respected dignitaries, governing body members of RAV, Director Ma'am, RAV Dr. Vandana Saluha, Gurujans. I welcome you all in another intellectual session of Gyan Ganga webinar series. I, Dr. Sangam Bhardwaj, on behalf of RAV, welcome you all for today's session. On the onset, we would also like to express our heartfelt gratitude and welcome our mentors who have always been there to guide, motivate, and encourage us for sustenance of this series. Respected Vaidya Sri Devendra Ganaji, President of GBRAV, respected Vaidya Sri Rajesh Gotecha Sir, Secretary Ministry of Ayush, and respected Dr. Vandana Saluha Ma'am, Director of RAV. Today's guest speaker is Dr. Rahul Dhanraj Ghuse Sir, Assistant Professor, Department of Kaumarbhritya, All India Institute of Ayurveda, Goa, who has joined us today in the 256th episode of this knowledge voyage. Let us begin the session by seeking the blessings of Lord Dhanvantri. Om Dhanvantri Namaha. Now I would like to introduce today's expert Dr. Rahul Dhanraj Ghuse Sir, who is going to throw light on the topic Cerebral Palsy Ayurvedic Review. Dr. Rahul Dhanraj Ghuse is an accomplished academician, researcher, and clinician in the field of Kaumarbhritya. He is presently serving as Assistant Professor, Department of Kaumarbhritya at All India Institute of Ayurveda. Previously, he served as Research Officer, Scientist at CCRAS, an alumnus of Gujarat Ayurveda University. He specializes in pediatric Ayurveda, Panchkarma, and clinical research. He has contributed extensively through scientific publications, research projects, academic administration, and national health initiative, reflecting his multidimensional expertise and commitment to Ayurveda and child health care. Now, I would like to invite Sir to please proceed with the lecture. Sir, you may continue. Sir.
Okay, thank you. Thank you for the introduction. So, give me 1 minute. Okay. My slides are visible now. Hello.
Yes, sir. Yes, sir.
Yes. Okay. Okay. I will start now. So, good afternoon, everyone. Respected Director Madam. Respected Director Ma'am. Today, I will be discussing on a topic on the cerebral palsy, and it is a topic related to the pediatric populations. So, first we learn the objective, what we are going to cover in this session. First, we cover the definition of the cerebral palsy. Afterward, we will discuss the etiology and the risk factors. Then we will discuss the pathophysiology. Afterward, we will see the classification of the cerebral palsy. Then we will see the clinical recognitions, and afterwards how to diagnose, that is diagnostic approach for the cerebral palsy. Then we will see the next to the comprehensive management of cerebral palsy, then functional assessments and some guidelines and advances. So first we start with the definition of the cerebral palsy. So as we all know that the cerebral palsy is a group of permanent motor disorders that affects the posture and movements that arise due to the damage to the developing brain. That means it is a group of permanent motor disorders which affects postures and movement in the children, and which is arise due to the damage to the developing brain, either in the uterus or in infancy. And cerebral palsy is considered as a static encephalopathy. That it means it is a non-progressive type of neuromuscular disorders. Means that damage which is happened at the time of birth is remains static. It never progresses as the age progresses. So it is considered as a static encephalopathy. So cerebral palsy is a static encephalopathy. However, some clinical features, motor manifestation, and musculoskeletal sequelae can evolve over the time as the child grows, right? And coming to the epidemiology, so incidence rate of the cerebral palsy globally, it is 3 per 1000 live birth, and in cerebral palsy it is the most common chronic motor disability in the childhood. अगर हम देखें तो cerebral palsy जो है, it is the most common chronic motor disability in the childhood, and the global incidence is 3 per 1000 live birth. Coming to the gender parity, males are more commonly affected than female with the ratio of 1.4:1, and CP prevalence is increases in the extreme of birth weight. That means extreme of birth weight means if the baby is very low birth weight, or on the other hand, if the baby is macrosomic, then the risk of CP is increases according to the weight. Also, the incidence of cerebral palsy is also increases in case of multiple pregnancy. Here we can see that in case of twin pregnancy is the ratio and the risk is higher, that is 5 to 8 times higher, while in case of triplets it is 20 to 47 times of higher. So in short, we can summarize that the incidence rate is globally is 3 per 1000 live birth. Male female ratio is the males are more affected than the females, and with the ratio of 1.4 as to 1. And the risk is also increases in case of the multiple pregnancy. In case of twin pregnancy it is 5 to 8 times higher, while in case of triplet it is 20 to 47 times higher. And in case of the one in case of the twin pregnancy, if the co-twin is demise, the in risk of CP is having in that in the live baby is significantly high. So in this way we can see the prevalence and that incidence rate of the cerebral palsy. Coming to the etiology and risk factor, that is the causative factors, nidana. So etiological and etiology and risk factors. In the etiology, we have three categories, that is antenatal factors, perinatal and postnatal factors, genetic factors. So coming to the antenatal factor, here we can see that 80% of the cases will have the history of antenatal factors, will have the presence of risk in the antenatal period. And in antenatal periods, the factors are related with the mothers. So we can see here that in antenatal factors, we have the first factor is intrauterine infection. That means, so if the infections, maternal infections causing the inflammatory response to mothers, suppose mother ko in pregnancy, during the pregnancy, if she is having some infections, so the chances of CP is increases. So the examples of that infections is chorioamnionitis, means there is swelling of chorion and amnion of in the uterus. Then maternal sepsis, if the mother is having UTI infections or any infections during the pregnancy, during the 9 months, during the third or trimesters. So there is a increase the chance of having the baby CP. Then Torch group of congenital infection. So intrauterine infection is the most common factor for having the CP in the future baby. Then come to the baby's factor, that is obstetric complications. If there is a placental insufficiency because of any reason, if there is a placental insufficiency, there is a lack of nutrition from placenta, there is a obstruction of obstructions or lack of nutrition from placenta to the baby. So placental insufficiency, IUG.
It's not audible, sir.
Audible, sir?
Yes, now it's okay.
Okay, sir. Okay. Coming to the perinatal factors, here in the perinatal factors, perinatal means the period from 7 month to 7 month to 7th day of after pregnancy, that is perinatal period. So inadequate oxygen, that is perinatal asphyxia, means hypoxia during the birth can cause the neuronal damage or brain damage, which can lead to the incidence of cerebral palsy. So perinatal asphyxia contribute only 8 to 10% of cerebral palsy cases. And coming to the neonatal complications, if the patient is premature, suppose the delivery or birth of the baby is happened before 37 weeks of gestations, then prematurity is one of the risk factor. Then if the baby is having some kind of infections after the birth, that is sepsis, neonatal sepsis or meningitis, then it can cause the cerebral palsy. Then kernicterus, that is severe pathological jaundice, because if the total serum bilirubin is more than 25 or 30 milligram per dl, then it leads to the kernicterus, and which can cause the damage to the basal ganglia in the newborn. And some metabolic injury like hypoglycemia happens at the time of birth. It also can cause the damage to the developing brain or developing brain in the newborn. So these are the factors which can increase the risk of having the CP in the baby. So we have antenatal factors, perinatal factor, and postnatal factors. There are some genetic and developmental factor also. Some genetic polymorphisms and mutations also increase the risk of CP, and some polymorphisms are identified, such as interleukin 6 genes polymorphism and factor 5 leading mutations. This also is responsible for having the cerebral palsy in the newborn. Then, as we see already in the epidemiology, that the low birth weight, at the extreme of birth weight, if the baby is having the very low birth weight or having the suppose the macrosomic baby, that is the birth weight is having 4 kg, that baby is also having the risk of developing risk of having the CP in the future life. And the risk is compounded by multiple pregnancy. We already discussed that in case of twins and triplets. In case of twins, the risk is 5 to 7 times higher. In case of triplets, is 20 to 47 times higher. So in this way, we have etiology, so, and these risk factors, and these risk factors are divided into antenatal factors, perinatal, and postnatal factors, some genetic factors, and there are two causes related to the weight of the baby and related to the multiple pregnancy. In this way, these are the etiological and risk factor of CP. Now we will move to the classification system. Coming to the classifications. So here we can see that the classification of the CP is based on the three different aspects. One is topographical classification, one is physiological classification, and one is functional classification. In case of topographical classification, we can see that this classification is based on the which part of the body is affected. Suppose we can see here in topographic classification we have monoplegia, diplegia, triplegia, hemiplegia, and quadriplegia. Here we can understood from the term that there is a defect. In case of monoplegia, we have the defects in the one limb. Diplegia means defect in two limbs. Triplegia means two limbs and one upper arm. Hemiplegia means two lower limbs, and that is quadriplegia means all the four limbs. That this is the basis. That the defect in the which part of the body is for the topographical classification. Then we have the physiological classification. Physiological classification is most important classification for the clinical practice. We have first is spastic CP, then we have dyskinetic CP, then we have the ataxic type of CP, then we have the hypotonic type of CP, and mixed type of CP. So it is in case of spastic CP, there is an increased tone of the muscles in the baby. In case of dyskinetic type of CP, there is a some uh, hyperkinetic movements in the hyperkinetic movements like dystonia, chorea, acidosis, like movements are present in the case of CP. In case of ataxic CP, in this case, there is a damage at the cerebellum region. So there is a posture and posture deformities in the baby. Then hypotonic type of CP, where there is a tone tone of the muscle tone is hypotonic. The baby is flaccid. And mixed type of CP means the combination of the two, that is spastic or dyskinetic or ataxic. Therefore, this type of classification will suggest us the type of the characteristics along with the damage to the which part of the brain. So physiological classification is used in the clinical practice. Then we have the functional classification. When we are doing any treatment to for the documentation of the improvements, we have these four types of categories. That is class 1, where there is a no limitation of activities. In class 2, there is a slight limitation of activities. In class 3, there is a moderate limitation of activities. And in class 4, no useful physical activity. Suppose we have a patient in our IPD and who comes with the class 3, and after treatments, there is a at the time of discharge we assess that patients, and if there is an improvement in the locomotor activities, then we can have the improvement in class 3 to class 2. This is for the only documentation of the treatment improvement. And physiological classification is important, which is used in the clinical practice. So classification is based only on the three types, that is topographical classification, physiological classification, and functional classification. As I told earlier that the physiological classification is the most important, and 80% and the most common type of CP among that physiological classification is the spastic CP. Most common type CP is the spastic CP among that 5 physiological classification, which accounts for 70 to 80% of all cases. So therefore spastic CP is the most common. And further, that CP, that is spastic CP, is divided into spastic monoplegia, spastic diplegia, spastic triplegia, spastic hemiplegia, and spastic quadriplegia. In this way, they divided that spastic CP into the 5 types: spastic monoplegia, spastic diplegia, spastic triplegia, spastic hemiplegia, and spastic quadriplegia. Here we can summarize these types of physiological types of cerebral palsy. Here we can say there are 5 types of CP. First one is the spastic CP, which is the most common. 70 to 80% of cases are from the spastic CP, where we can see the increased muscle tone in the group of muscles. We are in the spastic CP, and there are types of CP. The spastic diplegia. In case of spastic diplegia, the lower limbs are more affected than the upper limb. In case of hemiplegia, that is one side of the body is affected, and the one side of, and in quadriplegia, all the 4 limbs are affected. Second type is dyskinetic CP. The alternate name is for that the extrapyramidal CP. Here in this CP, the damage is at the level of the basal ganglia and thalamus. And in this type of CP, the clinical feature involves involuntary movements like choreoathetoid movements. Chorea means rhythmic jerky movements in the patients. In the clinical pictures हमें patients में देखने को मिलेगा कि patient will have the choreo type movements. Choreo means कि that's a immediate and rapid and jerky movements. Then dystonia means is the sudden contraction of the muscles and twisting movement. These are the clinical features which we will found in case of dyskinetic CP. Then we have the ataxic type of CP. In this type of CP, there is a damage at the cerebellum level. At cerebellum level, and because of the damage at the cerebellum level, we have poor balance and coordination in the clinical features. Patient is unable to walk. Patient is unable to maintain the balance and coordinations. There are also the tremors. Fine tremors can be present in the case of ataxic CP and dysmetria. Dysmetria means okay, suppose we want to locate some things like we have to that locate something by our fingers. So there is a overshooting or undershooting target. So a patient can't judge the coordination. So because of the damage at the cerebellum level. Then we have the mixed type of CP where multiple motor patterns are common, but most common is spastic quadriplegia and athetoid type of CP, that is dyskinetic CP. Means mixing of two types of CP is the mixed CP, and we have the atonic CP, that is hypotonic CP. In this type of CP, there is a reduced muscle tone. Here, in case of spastic CP, there is an increased muscle tone. In case of atonic CP or hypotonic CP, there is a reduced muscle tone, and the patient will be present with the floppy muscle tone. Patient is flaccid and mimics this patient mimics the muscular, like a case of muscular dystrophy. In this way, CP can be classified into 5 types: spastic CP, dyskinetic CP, ataxic CP, mixed type of CP, and atonic CP. So here we can see the classifications of that spastic CP. There's a spastic diplegia. Here we can see there is a increase muscle tone or spasticity in the lower limbs than the upper. In case of spastic diplegia, there is an increase of spasticity in the lower limb than the upper limb. In case of hemiplegia, there is a damage to the one side of the body, and in case of quadriplegia, all 4 limbs are involved. So spasticity in the one half of the body is the hemiplegia. Diplegia is the spasticity limited to the lower limbs, and then quadriplegia spasticity in the all limbs. These are the types of spastic CP. When coming to the diagnosis and assessment of CP, how we are going to diagnose and assess the patient, assess the cases of CP in our OPD basis or in IPD. So yes, we can diagnose the patients of CP by only first step. We have to follow these steps to diagnose the case of CP, because early diagnosis is very important to have the better prognosis in the cerebral palsy patient. So first we have to take the history, and while taking the history, we should be focusing on the antenatal factors, natal factor, and postnatal factors. As we already seen that in antenatal factors, we have maternal factors like intrauterine infections, obstetric complications, perinatal hypoxia. So during history takings, we have to focus on the antenatal history, natal history, and postnatal history. After that, we have to take the developmental history. Suppose the patient, because we learn that it is a group of permanent motor disorders. So we have to take the developmental history. If the baby is able to hold the neck, if the baby is able to sit according to the age, if the baby is able to walk or stand. So in this way, we have to take the developmental history also, and also along with the history taken, we have to do the clinical examination. Suppose we are seeing that there is an increased tone in a group of muscles, that is the spasticity. So on that basis, we can have an idea that the patient is having the delay in of the milestones, particularly gross motor milestones. Along with that, there is an increased tone of muscles. So we can have a suspicion of that this patient might be having the history, having the CP in his future life. Along with that, during the history taken, we have to rule out the progressive neurological disorders, because already we learned that the cerebral palsy is a static encephalopathy. It is a non-progressive neurological disorder. That means if the patient is having the damage of brain at birth, it never progresses to the other area. Like, but there are some conditions like neurodegenerative disorders, spinal muscular dystrophy, spinal tumors. In that case, that damage is progresses as the age progresses. But in case of CP, if we have the MRI at MRI of brain at birth, so, and if we do the MRI on the fifth birthday of that child, the damage will be the same in the MRI reports. That is why it is the static encephalopathy. And if we have the suspicion, then we have a investigation of choice, and the investigation of choice is brain MRI. So after history taking and examinations, we can have the brain MRI to confirm our diagnosis, right? Along with the history taken and clinical examinations, we have to do the some functional assessment. We have to do the assessment for the spasticity, and for that we will use modified Ashworth scales. It is the standard scales to grade the spasticity in the CP patient. So we have to use the modified Ashworth scale to study the spasticity gradings. Along with that, to assess the motor function of the child, we can use the GMFCS, that is gross motor functional classification assessment scales. We can use these scales also for the assessment of the motor activity of the child. Along with that, we can have the other investigations for hemiplegia. If the patient is of spastic hemiplegia, we have to rule out the we have to carry out the thrombophilic work of, because we already learned if the patient is having the genetic mutations, that is the gene mutation of factor V Leiden mutations, then it may lead to the that spastic hemiplegia, and for that reason we can ask for that thrombophilia workup. Most of the patients of CP will have the associate comorbid like seizures, hearing loss, deafness, vision deformity. For that purpose, we have to do the BERA for the rule out the deafness in the baby. Vision ophthalm checkup also needed. Then metabolic screening is also needed, because there are some inborn errors of metabolism which can cause the different types of CP, and genetic. If there is a continuous marriage history is there, so we have to ask for the karyotyping. In this way, we can diagnose the case of CP only by taking the detailed history along with the clinical examinations, and after rule out if the progressive neurological damage, we can confirm our diagnosis by the investigation of choice, that is brain MRI. Along with the examination, we can do the spasticity grading by the modified Ashworth scales, and some motor function assessment by GMFC scales. Okay. And lastly, we come to the comprehensive management. What is the comprehensive management in the modern sciences? So to treat the patients of CP, we need a multidisciplinary team, and that team should contain the general pediatrician, a pediatric neurologist. Before the some acute condition or for the seizure management, we need that pediatric neurologist. Then ophthalmologist on board. For the vision impairments, we need the ophthalmologist, ENT specialist for the deafness purpose, orthopedicians if the patient is having the severe contracture at the joints. If we want to do the tenotomy, then we need the opinion of the orthopedicians. And then for physiotherapist, occupational therapist, and speech therapist. Most of the patients will have the gait abnormality. Then some patients have the speech difficulty. And for that purpose, we need the speech therapist, that is rehabilitation therapy, that phototherapy, OT, that is occupational therapy, and speech therapist. Coming to the management foundations, we have four foundations, or um, uh, four steps of management in the CP. First one is the education and support. First, we need to give the counseling to the parents that having the CP does not mean that the end of the life. we have to counsel the patients for the what is the prognosis and what is the realistic goal which we are going to achieve after the treatment. So we should counsel the parents regarding the regarding the prognosis of the disease. Then we should train the caregivers, that is mother, father, for how to handle this baby, how to feed that baby, how to position, give the positioning while feeding. So these are, we have to give the education to the family members and caretakers. Then we have the second, we have the rehabilitation therapy. Rehabilitation for the rehabilitation we have physical therapy, that is for that is the physical therapy to improve the gross motor milestones, physiotherapy. So physiotherapy for to improve the gross motor milestones, that includes sitting, standing, walking, gait training. For that purpose, we need physiotherapy. For the fine motor activities and fine motor skills, we should ask for the occupational therapy. Some patients will have a difficulty of in fine motor skills, so we need to give the occupational therapy for the patients. And some patients will have the speech difficulty coming, so there is a main problem as drooling of saliva. In that case also we need to take the opinion from the speech therapist. So in rehabilitations we have physical therapy, that is physiotherapy, occupational therapy and speech therapy. Along with that, in patients of CP, we have some associate comorbidities. Like associate comorbid means कि patient CP का है और patients को seizures है, different different movements, spasticity है, dystonia है. For that we need to add the medications. And for here in the management of if the patient is having the seizures or epilepsy, then we need to add the anti-epileptic drugs. That, and we have to avoid the phenobarbital because of the possible side effect of cognitive side effects on the cognition of the baby. So we have to start the appropriate anti-epileptic drug for the management of seizure in the cerebral palsy patient, and for that we need that pediatric neurologist. Then we have the spastic CP, and then we have the dyskinetic type of CP. In that dyskinetic type of CP, we have different different movements, that is dystonia, chorea, athotesis, and for that we have oral medications like Botox injections to reduce the spasticity. Then for the dystonia, we have trihexyphenidyl. So we need to start those medications. Along with that, there are some certain procedures we need to give, some orthopedic procedures, because these patients are not able to walk. Their motor milestones are not achieved because of the disease atrophy. The patients have the contracture at the level of joints, and for that we need a orthopedics opinion or orthopedic procedures like soft tissue release. If the patient is walking on the toes, in that case also we have to do the tenotomy. Then we have some neurosurgical procedures in case of the severe refractory spasticity. Then in that case we can do the selective dorsal rhizotomy. And in case of the local spasticity, we can do the intrathecal baclofen pump. Baclofen is used to reduce the spasticity. Always remember that the baclofen pumps or the injection botulinum toxins and or baclofen is used to reduce the spasticity, and to avoid the systemic side effects, we can have the intrathecal baclofen pump, which can be there for the a localized group of muscles to reduce the spasticity in that localized group of muscles. And in advanced case, we can have the deep brain stimulation in case of the dyskinetic CP, where there is a deep brain stimulation is a type of neuromodulation therapy where we can implant the electrode in the brain area and giving some low power electric current in that brain area to stimulate that part of brain. So it can be used in the hyperkinetic type of CP, that is deep brain stimulations. So in this way, these are the managements available in the modern sciences to treat the CP. Now coming to the Ayurvedic review of the cerebral palsy, and here in Ayurveda, there is no exact reference. As we see go through the Bruhatrayi, there is no exact reference in Ayurvedic text that resembles CP. There are some few conditions or diseases that have some similarity in the etiopathogenesis and clinical presentation, and which includes Vadishpak, Vat Vedi, and Anatmat Vat Vikara. These conditions will have some similar type of clinical features or some similarities in the clinical presentation and etiopathogenesis. So we can correlate with the CP with these disorders. And in Ayurveda, CP is not a single disease. It is a complex of Vatvaidi manifestation. So influenced by Bija Dushti, that is genetic, and Kshetra Dushti. So in Ayurveda, there is no exact reference in Ayurveda for which resembles the CP. There are some conditions we can have these have the look of that conditions. In case of Vedic Fakka, according to Acharya Kashyapa, we can see the symptoms in the Vedic Fakka Pramlana Adhara Kayacha. That means diminished mass of lower body. Here in CP patient also we can see the diminished mass of lower body. Then Nitya Mutra Purisha Kruta, unable to achieve bowel and bladder control. Here in CP patient also there is a constipations and there is a involuntary of passing of the urine and stool. So we can correlate with this symptom with the cerebral palsy. Then nichest other kaya, that is immobile lower extremities. Then manda chesta, that is slow movements. Then shina mansa baladiti, that is diminished muscles and strength of the muscles. In Vatvikara Lakshana, we can see in Vata Jnanatmak Lakshana, that is Sankuchana, that is we can consider with the contracture, Khanjata, that is limping, Shosh, that is muscle atrophy, Stambhana, that is restricted movements, Chesta, that is chest. In case of abnormal movements, we can see in the disconnect type of CP, Chesta Hani, that is decrease movements. In case of hypotonic CP, Chalatva, that is unstable postures is there. We can correlate the associate conditions of CP with the Vata Jnanatmak Vikara. That is, Mukhatva can be considered as the language impairment. Badhirya can be considered as the hearing impairment. Ekangavad can be considered with the monoplegia. That is one part. Monoplegia means Ekangavad, one limb is affected. Pakshavad, that is one side of the body is affected. That is Pakshavad can be correlated with the hemiplegia. Sarvanga Rog can be correlated with the quadriplegia. All the four limbs are involved, and akshepa can be called with the convulsions. So, in conclusions, in Ayurveda, there is no exact relation of CP in Ayurvedic terminology. There is no exact relation of CP in Ayurvedic terminology, which is very difficult to have that correlation. However, based on the sign and symptoms and the nature of the disease, we can correlate with the CP with the Vat Vedi. We have different names, but according to Ayurveda, CP is predominantly a Vat Vedi disorder. It is not a single disease; it is a complex Vat Vedi manifestations for due to the genetic and uterine factors. According to the Ayurveda, we can have the etiological factors. We can divide this etiological factor into three categories. First one is the prenatal factors, then natal factors, and postnatal. Prenatal means is गर्भावकालीन निदान, that is which includes tulya gotra vivaha, improper garbhini paricharya, द्रवृत अवमानना. These are the factors which are responsible for the to create the malformation in the organs, malformation of the brains at the prenatal stage. Then we have the natal factor, that is improper prana praktyagamana, akala prasava, akala pravahan, and muda garbhata. So these are the factors which are the natal factor responsible for the CP. And then we have the postnatal factors, the Sharir Uddhikar Bhava Drushti and Bala Vruddhikar Bhava Drushti. So the etiological factors, that the causative factors are divided into prenatal factors, natal factor, and postnatal factors. Coming to this antenatal or prenatal factors, we know that the approximately 80% of the cases will have this and causative factors from the antenatal periods. First one is the Bija Drushti. We know that if the genetic defects affecting the sperms and ovum can lead to the can lead to the defective progeny. So also we found that there are some polymorphisms and gene mutation in the genes which is responsible for the CP, and 2% of the cases of CP are associated with the cerebral associated with the gene mutations or having the Bija Dushti. So this is how the Bija Drushti is responsible for the development of CP. Then we have the Ashaya Drushti, abnormalities of the uterus and placenta. Ashaya, the healthy uterus is always required to have the successful pregnancy. If there is a infections during the pregnancy to the mother, that is Torch group of infection, chorioamnitis, will have the adverse effects on the growing fetus. So Ashaya Drushti will also the cause. Then we have the Dav Hriday Vimanana. Davrida Avmanana, that is suppression of the maternal cravings during the pregnancy, will lead to the stressful pregnancy. And in Ayurveda also, if we do the Davrida Avmanana, that leads to the Kubjata, Panguta, Khanjuta, according to Acharya Sushruta. Then Their fourth factor is the Vata Prakop of Ahar Vihar or Abhigata. If the mother is having the Vata Prakop of Ahar Vihar or trauma, then it also can lead to the placental insufficiency, ultimately leads to the fetal hypoxia, and fetal hypoxia will ultimately lead to the brain damage. So in this way, we have Bija Dushti in the antenatal periods, Ashay Dushti, Davrida Avamanana, and Vata Prakopak Ahar Vihar. So in antenatal pictures, we are also maternal Vatprakopak Ahar Vihar and lifestyle. It also leads to the lower baby and IUGR babies. And we already learned that the low birth weight babies and IUGR babies have the higher risk of having the CP. Then Garbhini Jwara, very important. High maternal fever during the pregnancy, more than 103 fever, can cause the adverse events and can be associated with the neural tube defects, like prematurity, premature birth, and prenatal death also. So high maternal fevers can cause the CP in the newborn. Then Tulya Gotraviya, very important. According to Acharya, we should do the Atulya Gotraviya. Because of Tulya Gotraviya, there is a significantly increase the risk of having CP in the baby. So consanguineous marriage is one of the factor which is present in the antenatal period. Then drug toxicity. Acharya Kashyap already told that no medication should be given in the first trimester of pregnancy because in that period is the active cell division takes place. There is a formation of the germinal layers, and if we have any drugs during that period, it will definitely affect that process and leads to the CNS damage, and which ultimately leads to the CP. So these are the factors, that is Ahar Vihar Dushti, Garbhini Jwara, Tulya Gotriya Vihar, and drug toxicity. These are the antenatal factors for the CP. Then we have the natal and postnatal factors. That is, natal means during the birth. In natal factors, we have the Prasav Kalin Nidan. We have Akala Pran, means premature bearing down efforts can lead to the Murdabighat, that is head injury. If the mother is doing the premature bearing down efforts, it will lead to the head injury or intracranial hemorrhage, ultimately leads to the cerebral palsy. Then improper prana pratyagamana. If the patient is having the history of hypoxia at the time of birth, and if there is a delay in the prana pratyagamana vidhi, it ultimately leads to the brain damage, and it leads to the development of CP in the baby. So the Akala Pravahana and improper Prana Pratyagaman, these are the factors from the natal period. Then we have the postnatal factors, that is Stanya Dushti. After birth, we have the Stanya. According to Acharya Kashyapa, if the fetus, newborn is taking a milk or from the Tridosh Dushta milk or milk from the mother with the aggregated Vata and Pitta, which leads to the disorders like Fakka, that is rickets and malnutrition and developmental delays. Then we have the Graha Rogas like Skanda and Skanda Pasma, which are having the symptoms which are very much similar to the cerebral palsy. And then we have some environmental and protective factor, that is the absence of Sharir Uddigar Bhav or lack of Abhighat can also lead to the developmental delay and cerebral palsy like conditions. So in this way, we have Stanya Dushti, Graha Rogas, acquired diseases like CNS infections, meningitis. These all factors are from the postnatal factor or Prasavottar Kalin Nidana in the for development of CP. Coming to the pathogenesis of CP, as we know that these all, that is antenatal factors, natal factor, and postnatal factors, these all three nidanas will lead to the Garbhastha Shishu Uttamanga Sthandushti. And this Uttamanga, that is the Garbhastha Shishu Uttamanga, is the sthana of Pranavayu and Indriya. And Pranindriya Muladrishti will lead to the Pranavat Kriya Vikruti, because Pranvayu is also controlling its subtypes, that is Pran, Udan, Vyan, Saman, and Apan. And because of that, we have the symptoms like Mukatva, Pakshaghat, Pangulya, Drishti Vikruti, and Badhirya. And the pranavayu also controls the mana. Because of that, there is a chitta karma vikruti like zadatva and anavasti chittata. These are all the clinical features or all the are the feature of the cerebral palsy. So in this way, we can have the samprapti of the our disease according to the Ayurveda. And lastly, we come to the management strategy and prevention. What are the management strategy in Ayurveda? According to the Ayurveda, we know that the cerebral palsy is predominantly a Vata disorder, where Vat is avritta by kapha at the mastulanga level, and along with that there is also strotorod. So being a obstinance disease of vata, we need to do the vata shama treatments. And for that, we have the panchakarma procedures like snehana, swedana, nasya basti. So we have to do the vata vedic chikitsa. So we should do the snehan, sweda, nasya and basti. Then we have some preventive strategies. To prevent this disease, we should emphasize on the Garbhini Paricharya. We give proper antenatal care during the pregnancy and also decrease the what provoking factor during the pregnancy. Also include preventive strategy also include the infection preventions during the pregnancy, perinatal safety, and early screening via sanskaras. This is the preventive strategy for the cerebral palsy. Then we have the rehabilitations. Along with the Panchakarma procedure, we can have the modern physiotherapy to have the better results on the motor milestones or gross motor milestones in the patients. And for the internal medication or shaman chikitsa, we can have the Medya Rasayana drugs, that is Brahmi, Vacha, Jyotishmati, and Shankar's Pushpi. So we can manage this disorder with the help of the Panchakarma. We have to do the mainly the Vatvedi chikitsa, and for Vatvedi Shamana, we can have the Panchakarma like Snehan, Swedan, Nasya, and Basti. And this is the Chikitsa Sutra and treatment principles. It is the Chikitsa Sutra of Vatvedi Chikitsa Sutra, that is Vatasya Upakramam Sneham Swedam Sanchodhanam Mrudu Swadu Amla Lavana Ushnani Bhojya Abhyanga Mardanam Veshtanam Trasanam Seko Madhya Paishtika Gaudikam Snigdha Ushna Bastaya Basti Niyama Sukhashilata Deepana Pachene hi Siddha Snehacha Aneka Yonaya Visheshan Medya Pishita Rasataila Anuvasanam. So in the Chikitsa Sutra, we can, this is the Chikitsa Sutra of Vatvedi, and we can apply this Chikitsa Sutra to treat the patients of CP. Here we can, these are the Chikitsa Sutra according to the Ayurveda. First, we have to do the Dipana Pachana in the patients. Then we can have the Snehapan. Snehapan can be given Abhyanta Snehapan or otherwise a Bahya Sneha in the form of Abhyanga, Shiro Abhyanga. We can give the Shiro Abhyanga to the patient, Shiro Dhara to the patient, Shiro Pichu, and Shiro Basti can be given. In case of Svedana, we can have the Nadi Sveda, Upanaha Sveda, and Shastik Shali Spinda Sved to reduce the spasticity in the patients. Then we have the bastis. We can give the matra basti, that is sneha basti, kashai basti, that is madhudailik basti, and matra basti to the patients. Chaturbhadra kalpa basti, we have the kalpa in the kashyap sahita. We can have that schedule of bastis. Then we can have the nasya, that is nasa ishir sodaram. So we can have the brahmi grut nasya. Medya Taila nasya in treatment of CP. Then kriya kalpa, if the patient is having the ophthalm related issues or vision related issue, we can have the Netra Tarpana to the patients in consultation with the Shala Kerantra Vibhag. And and in Shaman Chikitsa, we can add the various drugs like Grita, Taila, there's a Brahmi Gruta, Sabvardhana Gruta, Abhaya Gruta, and we can add this different tail for the local application or external application for a Banga Bala tail, you know. Then Asa Varishta, if there is a patient is having the speech difficulty, we can add the Saraswata Rishta, the Shmula Rishta, and Rasayan Prayog we can also do. So in this way, along with that shaman medication, we can have uh, yogasana, physiotherapy, exercises. So in this way, we can have the treatment principles. But so first is Dipana Pachana, Snehana, Swedana, Basti, Nasya, Kriya Kalpa, Shaman Chikitsa, and Yogasana and physiotherapy exercises. So we can have a look on the Panchakarma procedure which can be done in the cerebral palsy patients. Here, this is the spastic cerebral palsy management. Here we can see that according to the Ayurveda, cerebral palsy the predominantly Vata disorders, where there is a kapha avrana to the vata at the mastulanga level. Along with that, there is a strotorod, because we can have the symptoms like stamba and gaura in the CP patient. So we can easily have an idea about the strotorod in the samprapti. So in the management protocol, because by seeing the pathophysiology, we can have a management protocol like first we have to do the avarana bhedana. And for that avarana bhedana, first we will do the udvardana. We have to administer the udvardana to the patient, because Urdhvatana induces the Rukshana guna to the body, and which helps to remove the kapha and ama avarana and blockage, that is Strotorodha. So first, in the patients of CP, we have to administer the Udvartana at least for 5 days with the Yava and Kulakta. After the Udvartana, to remove the cuff and Amaran, after Udvartana, we have to administer the Snehana. Snehana with the Ushna Tela, and then that is, Snehana and Svedana will brings the Mardavta to the body and the tissue becomes soft. So after Udvartana, we will have the Snehana. After Snehana, we can have the Shastik Shadi Pindasve, which will give the brihana to the muscles uh, s- s- which are the some we have some in Samprati that is sankoch to the sankoch and shosh to the muscles. In that case, we need the brihana. And at last, we can administer the various type of basti, that is shaman, because ultimately the basti is the prime treatment for the Vatavedi disorder. So we should administer basti to the patient according to the condition and age of the uh, uh, children, age of the child of CP. And we know that this basti can act on the systemic level via Pakwash and Majja axis, and that is gut brain axis. By through the gut brain axis, it can stimulate the central nervous systems and it can reduce the spasticity in that patient. So therapeutic sequence: first we have to Udvardhana, then Snehana, then Shastik Shali Pindaswet, and then Basti. And coming to the Udvartana, we all know that the Udvartana is the therapeutic massage by the herbal powders in direction opposite to the hair of follicles. So we can do the Udvartana with the help of Yava and Kulakta, and we have to follow the standard operating procedures, and we should be very careful while doing the procedures in the pediatric populations. So Udvartana is nothing but the therapeutic massage using herbal powders in a direction opposite to the hair growth. Then coming to the mode of action of Udvartana, this I already told you that the Udvartana induces the Rukshana Guna to the body, which helps to remove the arm and vitiated Kapha dosha. And as a result of that, it helps to open up the channels and it helps to remove the Srotavarod and prepare the body for further procedures like Abhyanga, Svedana, and Basti. So first, we need to administer the Udvartana. In modern science also, by doing Udvartana, it will help to improve the lymphatic circulations, and also along with that it also clears the orifice of the hair follicle, and because of that there is a mobilization of the absorbed drug to the target site by increasing the circulation. So it Udvartana increases the transdermal drug delivery, that is TDD, that is transdermal drug delivery. So before start the panchakarma procedure in the CP patient, we need to add or administer the Udvartana for at least 3 days or 5 days. Then after the Udvartana, we add Snehan and Snehan, that is Abhyanga, that is external application of medicated oil over the body. We all know that there is a in our classics also that the Abhyanga or Snehana is Zarahar, that is Vatahar, Pushtikara, Shramahar. These are the classical benefits written in our classics regarding the Snehan and Abhyanga. So we can add the Snehana after the Udvartana. Then after the Snehana, we have to administer the Svedana. In case of CP patient, we usually do the Nadi Sveda according to the age and sattva of the baby. Nadi Svedana. And we can also have the Shastik Shalipinda Sved, which is a snigdha type of Svedana. So,
Okay.
uh, hello, yes. So we can add the Shastik Shalipinda Sveda. And when
Okay.
this SSPS is a bolus fermentations in which the Shastik rice is cooked in the medicated decoction and milk. And after that, we can have the bolus of that formulation or pious formulations, and we can apply over the spastic group of muscles. So Shastik Shalipinda Sved also can be given because it gives provides the Bruhana Balya properties to the that emaciated muscles tissue or spastic muscles. This is the method of preparations. As we all know that we are doing the regularly in our Panchakarma departments. So we can have the cystic shalipindasis to reduce this for various research studies and articles are also published in case of cerebral palsy and the application of the SSPS to reduce the spasticity. Then uh, this is the mode of actions according to Ayurveda, how this Abhyanga and SSPS can reduce the spasticity in the CP patients. Here we can see that it is cystic shalipindasved and Abhyanga provides the Ushna Guna, Snigdha Guna, and Brihana Guna to the body. Along with that, the Ushna Guna of Ativarate. So, this Ushna, Snigdha, Bruhan, and Sushma Guna of both these procedures will help to specify the vitiated Vata dosha in the body of the CP patients, and which leads to the normalization function of the Prakrit Vata, and which, because we know that the normal function, this Prakrit Vata is responsible for control and regulation of mind. Along with that, it is also the instigator of all activities. Vayu Yadda Tantra Dhar. So it is the instigator of all activities. So we have, by doing this procedure, we have the normalization function of Prakritva. That is, it is the instigator of all activity. Then it is the instigator of speech also. It is the instigator of Agni. That is, all metabolic processes are depends on that Vata, and it also controls the excretory function of the body. That is the urine, feces, and spit. So by doing this procedure, we can have this Ushna Snigdha Purvana and Sushma Guna to the body, and which helps to specify the vitiated Vata dosha to break the samprapti of that cerebral palsy in the CP patients. While on the other hand, according to modern science, both these procedures provides heat, touch, and pressure to the body. With the warmth provided during these procedures will cause the mechanical hyperemia. As a result of this, there is a dilatation of the superficial blood capillaries. And because of that dilatation of the blood capillaries, there is a increase in the exchange of extracellular fluid and plasma, which correct the lymphatic channels and removes the obstruction in the srotas. Ultimately, we have the improved condition of the underlying cell and tissue, which help us for the normal and better functioning of the tissue. On the other hand, these all three, heat, touch, and pressure, stimulate the tactile and thermoreceptor in the skin, and that receptor convert the mechanical the stimulus or thermostimulus to the graded potential. And once the threshold is reached, that graded potential, the nerve impulse is generated, which propagates through the autonomic nervous system to the central nervous system, and which results into the reduction in the spasticity and pain in the muscles groups. So in this way, Abhyanga and Shastic Shalipinda can be used and can have the role or mode of action to reduce the spasticity in cerebral palsy patients. Then we have the Basti. You know all that Basti is that the per rectal administration of the drugs is called as Basti. And we know that the Moolasthana of Vata is the Pakvasha. And Basti is considered as the Ardha Chikitsa. So in case of Vata Vyadhi Chikitsa, we know that according to Ayurveda, cerebral palsy is the predominantly Vata Vyadhi disorders. And being the obstinance Vata Vyadhi disorders, we should administer the Basti. Acharya Kashyap also mentioned in the Khilastans the benefits of Basti in the pediatric population. So for the management of Basti, we for the management of CP, we should administer the Basti in CP patients. So why Basti for the spastic CP? So we know that the Moolasthana of Vata is Pakvasha, and Basti directly targets the Moolasthana, that is Pakvasha. Basti also provides the nutrition, that is Burhana, to the emaciated limbs. We know that in spastic CP patient the limbs are emaciated, that there is a shosha. So we need a Burhan. So we can have the effect of Brihana effect by the Basti. Then there is a neuro regeneration, there is Rasayan properties of the Rasayan properties, and to improve the Majja Dhatu, that is nervous tissue. By stimulating the gut-brain axis, we can have this neuro rejuvenation effect. And Strotoshodhana, we know that along with the Mala and Dosha, Basti expel all the Mala and Dosha through per rectal route. So it clears the micro channels to reduce the spasticity. So that is the reason why we administer the Basti in the spastic CP. And among the Basti schedule, we administer in that Yoga Basti in the pediatric population because of because Yoga Basti is indicated for the Mrudu dosha, and it is safe in the pediatric age group also. So we always choose the Yoga Basti schedule to administer the Basti in the CP patients. And we have some research works. I have also completed my dissertation on the Madhudailik Basti in the management of CP, and we in my PG days we selected this Madhudailik Basti with the reference of Sharangar Uttarakhand. And these are the specialities of that Madhudailik Basti. That is it is the Mrudu form of the Nirva Basti. It can do the Lekhan and Brona too. And it is neither Ekanta Lekhan nor Ekanta Bruhans. So and perform Shodhan without causing the Vata Viseshan. And that is the reason why we selected the Madhudailik Basti for the Nirva purpose in Yoga Basti schedules. And by giving the Madhutailik Basti, we don't have any complications, reported complications, and no specific dietary regimens we have to follow. So no dietary restrictions we have to follow during the course of Basti, and we can allow the patients to for travels, and it can be administered at any time. So because of that, the Madhutailik Basti is also Rasayan also. So we choose that Madhutailik Basti for the treatment of CP. This is how the Yoga Basti schedule. According to Acharya Charaka, this Yoga Basti contains 8 bastis, in which 3 are Niru and 5 are Anuvasan. On the first day, we will administer the Anuvasana. After that, 3 Anuvasana and 3 Niruva alternatively, and lastly 1 Anuvasana. So in this way, we can administer the 8 days, 8 bastis through this Yoga Basti schedules in the CP patients. This is the contents of that Madhudailik Basti, and the reference is Sharangdar Sahita Uttarakhand 6/28. And we know that the method of preparation of the Astab, that the Makshikam, Lavanam, Snem, Kalkam, Kautham iti kramat. In this way, we prepare the Basti and follow this Yoga Basti schedule of 8 days. Then this is the dose given by the Acharya Charak in the Charak Siddhistan, and we are following the same for the administration of Basti in the CP patients. And the mechanism of actions, that is the mode of action of Basti therapy. We know that Basti is the Vata Harnanam Sreshta. And being the obstinate disorders of the Vata, we have to give the Basti to these CP patients. First one is. Second option is the second benefit of Basti is that the rectal absorption kinetics. That is rectal route, by giving the medications to the rectal route, it bypass the first phase of hepatic metabolism. And because of this, there is a more bioavailability of the drugs through this route. So we can add, and there is no palatability issue. We can give the Basti in a large quantity also through the rectal route. So there is no palatability issue also. And that is why we are doing the Basti in these patients. Then we have the third benefit is Trotoshodan and Sukshma. We know that the ingredients like Saindava, which is present in the Basti Dravya, it penetrates the microchannel and removes the Strotorodha. So Basti help us to do the Stroto, to remove the Strotorodha from the body. Then we know that the Saindava, by adding Saindava, there is an increase the concentration of the sodium ion in the body, and that sodium ion will produce the osmotic gradient in the mucosa of the intestine, and because of that, it will absorb more water and drugs from the Basti. So it will help to the for the better absorption of the drugs in the rectal mucosa. Then we have the Brihan and Rasayana effect of Basti, because it will nourish the Dhatu systematically. Madhutailik Basti basically promotes the strength and neuro regenerations. In the Falashruti of Madhutailik Basti, there is a Rasayana, Balya and Bruhana, and that is why it is selected for the CP patient, because in this patient we have the emaciated limbs, shosh, right? So for that purpose, we selected this Madhurailik Basti, and the Sneha present in the Basti, that is Ati Balatela and Ati Balatela, Marchatela. This enhance the cell membrane permeability, and because of that, there is a good absorption of the drugs in the Basti. So these are the mode of actions or mechanism of action of Basti, how the Basti will help in the management of CP in pediatric populations. So in this way, we can have the first Udvardhana, then Snehana, then Shastikshali Pindaswed, and then Basti procedures. So this is the management protocol for the Basti. So I will stop here. This is from my side. Thank you.
Thank you so much, sir. Now I request, if anyone having any doubt, you may please ask to sir.
हेलो साहब, बहुत बहुत धन्यवाद। बहुत सुंदर आपने व्याख्यान दिया।
जी सर।
4 घंटे थे, बहुत अच्छा व्याख्यान दिया आपने ये।
जी सर, थैंक यू सो मच सर।
विद्यापीठ को अच्छा, कुछ विशेष योग देते हैं डॉक्टर साहब, कुछ क्या आप अपने इनमें?
जी सर,
कुछ योग देते हैं बना करके?
हाँ सर, बना करके शमन चिकित्सा में, जैसे कि हमने डिपेंड्स ऑन द कंडीशन, कि अगर पेशेंट्स को, जैसे हम मेद्य रसायन है, तो हम शंखपुष्पी, यष्टि मधु, ब्राह्मी, बचा, पिपली, ऐसा ही वैद्य रसायन ड्रग दे सकते हैं क्या, या फिर क्लासिकल फॉर्मुलेशन ऐसा जैसे संवर्धना ग्रुत है, अभय ग्रुत है, ब्राह्मी ग्रुत, तो ये हम यूज करते हैं। किसी पेशेंट्स को अगर स्पीच डिफिकल्टीज है तो वी कैन हैव सारस्वता रजिस्टर अलोंग विद द स्पीच थेरेपी, क्योंकि यहाँ तो संस्थान में हमारा स्पीच थेरेपी यूनिट भी है। तो जो पेशेंट्स को जिस प्रकार की जरूरत है, एसोसिएट जो कंडीशंस है अलोंग विद द सीपी, हम उस प्रकार से उसको मैनेजमेंट प्रोटोकॉल डिसाइड करते हैं सर।
चलिए बहुत अच्छा। आप कहाँ कॉलेज में हैं? आप कॉलेज में?
यस सर, मैं यहाँ पे अखिल भारतीय आर्य संस्थान में यहाँ पे सह प्राध्यापक पोस्ट पे कार्यरत हूँ।
अच्छा, यहीं पर नोएडा मतलब दिल्ली में है?
जी सर, ये गोवा में अभी जिसका सैटेलाइट इंस्टीट्यूट है ना
हाँ
सर।
हाँ, उद्घाटन हुआ था जब हम लोग गए थे, माननीय प्रधानमंत्री जी आए हुए थे उस समय।
जी जी सर, वहीं पे वहीं पे।
ठीक है ठीक है। दीक्षित जी तो हमारे मित्र हैं अच्छे।
जी सर।
चलिए बहुत अच्छा है डॉक्टर साहब, बड़ा अच्छा रहा इसी माध्यम से आपसे मुलाकात हो गई।
जी सर।
और कोई विशेष रोग पर है आपका, विशेष रोग पर इसके अलावा?
सर मैं समझा नहीं सर, क्या बोल रहे सर?
कहते कोई और रोग पर है कि आपकी अच्छा अनुभव किसी अच्छे रोगों पर?
सर हमारे यहाँ पे अभी जो हमने एक प्रयास यूनिट शुरू किया है जहाँ पे न्यूरोबेरल डिसऑर्डर्स जैसे एडीएचडी है सर, एएसडी है,
हाँ, हाँ,
सोरियासिस है सर पीडियाट्रिक में, जिसमें हमने बिफोर ट्रीटमेंट आफ्टर ट्रीटमेंट विद इन 3 मंथ्स सिम्टम फ्री स्किन पेशेंट्स को आया है, और विदाउट मेडिकेशन पेशेंट इज नाउ स्टेबल। सो हम तो सॉरी पीडियाट्रिक सोरियासिस पे काम कर रहे हैं, फिर एडीएचडी पे काम कर रहे हैं, एएसडी पे है। गोवा है तो यहाँ पे एलर्जिक राइनाइटिस भी बहुत ज्यादा प्रिडोमिनेंट है, तो उसमें भी अभी इंट्राम्यूरल रिसर्च प्रोजेक्ट हमने सबमिट किया है सर, कंप्लीट करके। सो
चलिए बहुत बहुत आशीर्वाद, बहुत बहुत बधाई, सुंदर आपने व्याख्यान दिया।
जी सर, और किसी को कोई क्वेरी है तो आप पूछ सकते हैं।
Hello.
हाँ जी।
Uh, I'm Dr. Krishnaya from Tirupati,
यस
Aryavi
सर।
Guru
यस सर,
in
नमस्ते
Boston.
सर।
Namaste. See, it is, the most of your lecture has been the theoretical part.
यस
See,
सर।
here you said that the textual, modern textual presentation.
यस सर।
See, it is true that in textbooks, the textual knowledge, 80% is the prenatal causes and 20% perinatal or postnatal. See,
यस
what
सर।
is your experience? May I know your experience? Is
सर
it true?
yes sir, because I have my dissertation on that cerebral palsy in 2012, and in my I enrolled that time 23 patients because of the less prevalence in the Jamnagar. But when I saw the observations that there is a 80% factors are from the antenatal period basically. That is the maternal infections, because of the maternal aggravation of the Vat Prakopa Ahar Vihar. Yeah, so antenatal factors plays a more role than the different factor like perinatal factor like perinatal asphyxia. At that time I thought कि पेरिनेटल एस्फेक्सिया दैट इज हाइपोक्सिया, कि अगर बच्चा जन्म के वक्त रोया नहीं तो it will lead to the cerebral palsy, but it contribute only 8 to 10%. And after that, after my dissertation work, there are 12 to 13 works which are being done in the Jamnagar, Jaipur, and here also in All India Institute of Ayurveda. And the same we don't have any contradictory findings with the books. Though antenatal factors are the most important factor for contributing to the cerebral palsy, sir.
But my experience is quite contrary to this.
Yes, sir.
The,
What is your
I,
experience, sir?
my I have experience of managing cerebral palsy cases, probably few thousands of cases. I have some 40 years experience.
Yes,
Uh,
sir.
Here, the majority of the cases are perinatal and
Perinatal. Okay.
perinatal birth asphyxia.
Which factor? Perinatal asphyxia, sir.
Birth asphyxia was
Yes.
the prime cause of cerebral palsy in my experience. When I have taken out the statistics of my studies, it
Yes,
was
sir.
perinatal causes mainly birth asphyxia. The
Perfect.
maybe delayed labor or something else, the fetal distress or whatever the reason.
Yes, sir.
It is totally contrary to the textual. The
Textual
80
findings, sir.
cases are perinatal causes, birth
Okay.
asphyxia, and
Yes, sir.
only some 10-15% postnatal causes, any severe illness after birth or in
But
the first step of life. So
yes,
that's
sir.
okay because
Sir,
and you that
sir,
the references of Jamnagar, and I am also from Jamnagar.
yes,
So
sir.
Jamnagar and the Jaipur, we have compared the statistics. But this is my experience. I wanted
Sir,
to share. And the
I,
number
sir.
etiological factors. It is the first time I have come to know of your presentation that Fakkaroga is the causative factor of cerebral
No,
palsy.
no, sir. Fakkaro can be considered as a malnourishment, but to understand, like Pramlan Adharakayach, we can have the idea that in Ayurvedic classic there is no direct correlation, sir. No, we are not correlating
That
the
is
Fakka with the
that is
CP.
true. You are
Uh,
right.
yes,
But
sir.
it is the Fakkaroga is purely a nutritional disorder.
Yes, sir. It is a malnutritional
Normal
disorders.
even severe the carbohydrate the deficiency, the
Protein and the
malnutrition.
malnutrition. Yes, sir. Yes,
So
sir.
the child is having the no nutrition, and so the in protein malnutrition, he is unable to move, but he is able
Yes.
to see. There is no sign of paralysis
Yes, sir.
in
Yes, sir.
none of the Fakrogas. There is no sign of paralysis.
Yes, sir. I
So
mentioned that Pramlan
is that
Adharakayach just for the sir that we have some discrete symptoms in our classics which can correlate with the CP symptoms, but I am not correlating the CP with the Fakka, sir.
that is that means the Fakka should not have come in the explanation of
Yes, sir.
cerebral
Yes,
palsy.
sir.
That is
Okay,
my
sir.
opinion.
I will note that, sir. So it
Number
is yes, sir.
number two, see, when you have come to the treatment aspect,
Yes, sir.
the, before that, you never mentioned about Samprapti, that is Kaphavrutavata. But at
Ah,
the time of the explanation of treatment, you said Kaphavrutavata, that is the reason why the Udvartana
Udvatana.
has the first type of management. But I don't think this is a Kaphavrutavata. And
Mm.
the Udvartana, I don't think it is an appropriate beginning of management in cerebral palsy because the children are very young, and
Yes, sir.
Udvartana is a bit the rough treatment.
Yes,
So
sir.
that is another thing I noticed. No, no,
Mhm.
just whatever the things I noticed because I'm sharing my vast experience of cerebral
Yes, sir.
palsy man.
I am also writing your point, sir. But
Uh,
in my protocol also, I administered the Udvartana for 5 days to the cerebral palsy patients in 2012, and I passed out in 2015. So, and after that, we are follow the same protocol, and according to our sir, that is Dr. Rajagopala sir, and as the person, according to sir, there are the symptoms of Stamba and Gavrava. And being a obstinate Vadi of Vata disorder, why you are adding the Udvartana to increase the Vata again? So, according to our sir, sir said that there is a Stamba and Gaurata in some part, and so we think about the Kapha Avrana to the Vata, and for that reason we administer the Udvartana. And I practically applied the Virechana for at least such 5 days in 3 sittings because my protocol was 15 days protocol with 15 days gap. But yes, it is. There are some challenges to administer the Virechana, sorry, Udvartana and this Basti procedures. But we administered Sir Udvartana. But I am also writing your point, sir, because of your experience, sir. You are our guru, sir. So I will definitely have this finding to in our practice also, sir. We will try, sir.
that is because in Udvartana, in older children, wherever obesity and like that, as a
Yes, sir.
Kapha is the
May
predominant
the
one.
prevalent
But
properties,
then
sir.
Udvartana is okay. But in my view, in pediatric cases, Udvartana, we have to think and administer. That is another thing.
Yes, sir.
So when coming to the management, that's okay.
Yes,
Uh,
sir.
here, in etiological factors, the the birth injuries, our cerebral palsy features are very close to the Murdhabhigatanam.
Yes, sir.
Murdhabhigatanam. So this birth trauma in which the head injuries can cause damage to the brain.
Yes, sir.
And so the clinical features also very close to that of CP. So Mudha Bigatanam is, yeah, as you said, it is the no single clinical disease entity can be compared with, but Mudha Bigatanam seems to be more
Yes,
appropriate.
yes, sir.
Course,
Yes, sir.
whatever this Nanatmaja Vyadis, we can consider there's no wrong in it.
Yes, sir.
So that is, and because still you are an young teacher, so here I would like to suggest one thing: Lala Shravam,
Yes,
the
sir.
rolling of saliva.
Yes, sir.
So it is not appeared in your management. It is very common in spastic cerebral palsy.
Very common, sir.
Very common, and I do not know whether with just with my experience I'm telling you
Yes,
this
sir.
the what is this
Vachachurna.
no, not vacha. What is the drug which is having dopamine like action in Ayurveda?
That ये कम Kapikachu.
Atmagupta. Atmagupta.
Yeah,
Kapikachu.
the Yogita Atmagupta is very effective in especially in Lala Srava.
Yes, sir. Thank you so much, sir.
So you can try. Just let me know after your experience. That
Sir,
is very
sir, for
especially
internal use or for local application to the Jiva?
not local application, internal
Inter
use,
okay, sir.
oral use internally.
Okay,
We
sir.
are not promoting the company, but
No,
the
sir.
Jando company prepares one drug known as Jandopa.
Okay,
So
sir.
that is given orally. The
Ah,
within a weeks, you will get a very good improvement in the drooling of the saliva.
yes, sir. I
You
will
just
definitely
uh,
try, sir.
in number of the patients.
Okay, sir.
That is very useful. That is so. And you didn't touch anything about Rasoshadas. Have you any experience
No,
or any reference Rasoshadas in cerebral palsy?
no, sir. I did not use any research that yielded, sir.
Okay. Yes, sir. Anyhow, congratulations and very good, the very vast presentation. And thank you.
Thank you so much, sir, for your guidance, sir.
हेलो सर, गुड इवनिंग।
हाँ, sir. Namaste.
सर नमस्कारम। सर मेरा क्वेश्चन था, जैसे बच्चों में स्टैमरिंग की प्रॉब्लम होती है एंड स्पीच प्रॉब्लम, तो उसमें हम क्या एडवाइस कर सकते हैं?
स्टैमरिंग एंड स्पीच जो प्रॉब्लम्स है, पहले तो हमें पता होना चाहिए कि ये एसोसिएट कंडीशन है किसी डिसऑर्डर के साथ, सो वी हैव टू ट्रीट द फर्स्ट प्राइमरी डिसऑर्डर्स आफ्टर द वर्ड्स we can have some because stammering is due to the CNS involvement or may not be with the CNS involvement. If there is a CNS involvement, we can have method drugs, and along with the we have also some Vani Shodhak Rasayan, that is Saraswata, that is Suvarnayukt and Suvarnarahit. So we can try this also. Along with that, in Ashtang Hruday Uttar Tantra, we have that Vani Shodhak Yoga. So we can also try also that yogas, and the most important is to have the speech therapy also, because if you want to much improvement na, along with the medication, we can all start the speech therapy. So this is the for the speech difficulty or speech issues, we can have the internal medication and speech therapy. Hello.
थैंक यू सर।
Okay. Okay.
On behalf of the organizing committee, I would like to thank Dr. Rahul Ghuse sir for delivering such an insightful lecture. I would like to extend my sincere gratitude to our mentor, Dr. Dhanraj, for his continuous support, guidance, and blessings. I thank our director, Dr. Bandana Silva, standing for all the events of RA. I would also like to thank Ben Rajesh, sir, Secretary, Ministry of Finance, for his participation and encouragement in all our efforts. Last but not least, I thank each member of RAB organizing team who work behind the stage to make this session a successful one. Thank you so much, sir.
I would also like to thank the Dr. Director ma'am for giving me opportunity to present, be a part of this series. Thank you so much.
Thank you.